time for Clinical Journal Club for this week that I had to lay on Monday rather than Wednesday. And so we'll get started with the clinical adventures for this week, and they are many. The image out of the New England Journal is this chest x-ray from a 3-year-old child, probably AP since the heart looks fairly large. And what we can see is that there's a foreign body lodged in the upper mediastinum. We don't have a lateral view, but it's almost surely in the esophagus. That most objects that are round and swallowed by mistake or by children or whatever have you pass without difficulty. So I would think that the small coins, chewing gum, small plastic buttons, and pencil top erasers would probably pass. But this object is irregular. It has one sharp point. We don't know exactly how long it's been there, but I would think that it's probably stuck in the upper esophagus and we ought to get rid of it. And so that's the answer. And so foreign bodies that have not moved in 24 hours that are easily accessible should probably be removed. It's not a toothpick. Last week we had the disaster with the toothpick, and toothpicks generally don't pass spontaneously. The first topic in the New England Journal this week concerns molecules with these structures, and if you'll recognize the basic tetracycline motif here. And this is a new tetracycline drug called Omadacycline. It has a broad spectrum. It's well absorbed orally. It's active against a number of organisms that are associated with common infections, including Staphylococcus aureus and methicillin-resistant organisms and bacteria of this sort. Tetracyclines work by binding to bacterial 30S ribosomes and impairing protein synthesis. And the first study involves the treatment of pneumonia, community-acquired pneumonia, which is a common clinical problem, has to be assessed clinically. We would expect that these patients might have fever, skin changes, cough, sputum production, pleuritic chest pain, hemoptysis, etc. They may have muscle aches and fatigue. They might have tachycardia, possibly also nausea and vomiting or joint pain, some central findings such as headache or loss of appetite. And these patients have to be assessed clinically in terms of severity to determine whether or not they really have pneumonia or just upper respiratory infections, colds, bronchitis, etc. And so we stratify these patients clinically in terms of a Pneumonia Severity Index. And the severity index is a function of age, heart rate, respiratory rate, blood pressure, history of underlying problems such as cancer, heart failure, stroke, kidney disease, and liver disease. Then we can subclassify these patients further in terms of the clinical features that are shown here on the right, add these things up to establish a risk classification. That was also done in this study where excuse me, Omadacycline was compared to a gyrase inhibitor. So here patients with pneumonia were recruited from various centers, and they were randomized to either Omadacycline or moxifloxacin. Their pneumonia severity scores given here were similar in both groups, and various other clinical characteristics that are shown here were also equally distributed, so the randomization worked appropriately. Now, there are inclusion criteria in this study, and the patients had to have fairly high probability of having outside of the hospital acquired pneumonia. It had to be appropriately severe. Diagnostic criteria in terms of determining what sort of a bacterial etiology was responsible was applied in this study quite successfully, I believe. Chest x-ray was required with changes consistent with pneumonia and various other risk factors as given. There were also exclusion criteria that involved other underlying diseases, immunosuppression, etc., or features that were not consistent with a community-acquired pneumonia. So we can look at the patients. There are 877 patients that were considered. Fairly high numbers were randomized to both treatment arms, and a large number of patients were then followed for the duration of the study. A culture was obtained. Gram stain and sputum was also obtained. Then there were other diagnostic tests that were applied here, including positive urinary antigen tests for Legionnaire's disease or serological tests, etc. Molecular biology was not applied, but the investigators were able to get a pretty reasonable idea of the definitive organism in about half the cases. Now, these studies are mandated by the FDA, so they're designed in principle to look at the notion that the new drug is no worse than the old drug. And when we look at the end results here, we can conclude that Omadacycline was no worse than moxifloxacin. So this is a statistical criteria that's applied here. So indeed, the new tetracycline is no worse than moxifloxacin, which was also successful in treating these patients to a similar degree. If we look at the organisms that are involved here, pneumococci were high on the list, Haemophilus influenzae, mycoplasma, but also some examples of Legionnaire's disease and other definitive organisms were also found, but the distribution of the infectious agents would be what we would expect in patients with community-acquired pneumonia. There were 8 people that died in the amoxicillin group compared to the moxifloxacin group where only 4 people died. So I looked in the supplement to see what was going on here, and these patients were critically ill for various reasons, including the presence of unexpected aortic aneurysms, myocardial infarction. We learned several weeks ago that pneumonia in patients of this age is associated with the substantial increase for having an acute myocardial infarction. Strokes occurred, but I couldn't conclude that omadacycline is more likely to result in this kind of an outcome compared to moxifloxacin. So in this study, once a day omadacycline, the drug was given intravenously for the initial portion of the study, and then with oral therapy was no worse than moxifloxacin, which was also equally successful in treating this particular infection. The next paper in the New England Journal is basically the same story. Here we look at the tetracycline antibiotic compared to linezolid. Linezolid addresses the 50S ribosomal fraction of ribosome bacteria and also impairs protein synthesis. And here the issue is skin infections, cellulitis and other forms of skin infections, soft tissue infections were addressed here with these 2 drugs being applied as therapeutic agents. Again, this is an FDA mandated study, so the endpoint is showing that the new drug is no worse than the old drug, which is certainly reasonable drug to apply for skin infections of this sort. So these patients were randomized to oral omadacycline compared to linezolid, and thereafter the treatment duration was between 7 to 14 days, and the primary endpoint is an early clinical response that can be determined by lesion size and other clinical parameters, and without the requirement for rescue therapy because of bacterial resistance or what have you. So we look at these patients, and there are more than 300 patients in both groups. Men and women are equally represented. Infectious types, it's mostly cellulitis or erysipelas or subcutaneous abscesses. And what we can see here, same result, omadacycline is no worse than linezolid. and both drugs were effective in treating subcutaneous infections. Now here organisms were also isolated. We see here methicillin-resistant organisms in both groups, but methicillin-resistant staphylococci should be sensitive to both of these antibiotics, as was the case here. Additional infectious organisms were identified, similarly distributed in both groups. In terms of adverse reactions, gastrointestinal complaints and various things were similar in both groups. There was no difference in mortality, and thank goodness very few people died in both of these treatment groups because the treatments were successful. So the end result is that Omadacycline is no worse than linezolid in the treatment of these kinds of subcutaneous bacterial infections. And in the editorial, basically the editorialist asked the question, so what? But then again, these studies are done so that new compounds are then available for clinical usage, and I think that Omadacycline will be approved for these two indications for the treatment of outside of the hospital acquired, community acquired pneumonia or subcutaneous infections, skin abscesses, cellulitis, erysipelas, etc. The next topic in the New England Journal involves acute heart failure. And as a little background, you're aware of the fact that natriuretic peptides, most of these come from the heart, but they're also synthesized in other areas of the body. There are three particular types, three separate genes that are responsible for their synthesis. They operate on endothelium to result in vasodilatation. They operate on the adrenal glands to decrease the production, the release of aldosterone, and they operate on the kidneys to induce natriuresis. So these are natriuretic peptides. And they're a good thing to have when you have heart failure. And natriuretic peptides are degraded by an endopeptidase. It's basically a matrix metalloproteinase. And that degrades these natriuretic peptides so that their action would be diminished. Now, this peptidase also degrades angiotensin II, which might be an undesirable effect. The renin-angiotensin system and its role in heart failure are known. So with this particular strategy, neutral endopeptidase inhibitor called sacubitril is combined with valsartan, which blocks the angiotensin II AT1 receptor to deal with that particular problem so that we have renin-angiotensin system blockade and at the same time a robust action of natriuretic hormones. That's the idea with this particular strategy, which has been developed by Novartis. Now, valsartan is said to have an action of duration of 24 hours. I think that's probably optimistic. So in this particular study, this compound and its control compound, enalapril, were given twice a day. So again, these neutral endopeptidases degrade numerous small peptides. Natriuretic peptides is one. The degradation of angiotensin II is complicated, won't go into that further. Bradykinin, oxytocin, substance P, and other small peptides are degraded by these neutral endopeptidases. Now, this strategy has been tried before for patients with heart failure, and the Paradigm HF study was published several years ago. And in that study, enalapril was compared to this combination of neutral endopeptidase inhibitor and valsartan. And what we see here is that the double strategy was better for a primary endpoint in this study, which was a collective endpoint, but also better for death from cardiovascular disease, hospitalization from heart failure, or even death from any cause. Now, if we look at the absolute difference here, the number needed to treat is about 30, which I guess is acceptable. But this study was criticized also because the funding source was solely related to Novartis. So Novartis is, of course, interested in other studies that might underscore this clinically present but perhaps small benefit of this strategy for patients with heart failure. So these patients have acute heart failure. They probably also have chronic heart failure, but they came to the hospital in essence with acute pulmonary edema. And what was done here is these patients were relieved of their previous treatments, if they had renin-angiotensin system blockade, etc. And then after a short period of time to allow these compounds to wash out, they were randomized to sacubitril plus valsartan compared to enalapril alone. And enalapril was given at a dose of 10 milligrams, but it was also administered twice a day, as was the combination of sacubitril with valsartan. So if we look at these patients, these are mostly men, middle-aged, with heart failure from, this is all reduced ejection fraction heart failure. So the problem here is squeeze, not relaxation. The severity of heart failure, most of these patients have New York Heart Association classification of stage 3, some also stage 4. And they have, as was required for entry into this study, elevated levels of natriuretic peptides, which is a biomarker for heart failure. And the primary endpoint here was, in essence, the reduction of this biomarker. And what we see here is that the patients with the combined therapy had a greater decrease in NT-proBNP compared to the patients that received enalapril alone. And that was still documented 8 weeks after randomization. So the positive endpoint, which is superficially not that thrilling, was supported the combined treatment strategy. Now, the investigators included so-called exploratory clinical outcomes. Now, these are not primary outcomes, these are secondary outcomes, exploratory outcomes. At least they're largely in favor of the dual strategy because the numbers here are not large enough for any statistical inference, but the rehospitalization for heart failure was about half as great, and the number of deaths seemed to favor the combined treatment. And if we look at various subgroups here in terms of age, gender, race, previous episodes of heart failure, hypertension, atrial fibrillation, etc., it looks like the dual therapy is better than giving enalapril alone. So we hope that these exploratory clinical outcomes, which were hard outcomes, will be substantiated in future studies. The next topic is also not easy, and it concerns porphyrias. And the poor medical students have to learn the identification of about 8 enzymes that are involved in the synthesis of heme. Now, the heme molecule is synthesized by about 80% of all living cells, so most cells can do this, but the primary action is, of course, in the erythron, because erythrocytes have to be filled with heme, and also in the liver. And there are various enzymes that are involved in this process. And there are also degradatory pathways that are important, and this is how heme is converted to biliverdin and bilirubin, etc. Now, there are numerous reasons to have porphyrias, and about 4 of them are related to mutations that are involved in this cascade. And one classic one is porphobilinogen deaminase. This is basically a hepatic porphyria. This enzyme is primarily present in the liver. The substrate here is supplied by delta aminolevulinic acid synthase that places aminolevulin for disposal for further metabolism from porphobilinogen to the next step. So the people that have a mutation in this gene, and the mutation is relatively common, and it's autosomal dominant, although the phenotypic expression only occurs in about 10% of the patients that have this problem. And there are many mutations in porphobilinogen deaminase that are responsible for acute intermittent porphyria. So you have to know something about this problem. Now, the porphyrias have all sorts of amazing phenotypes. 4 examples are shown here: cutaneous changes and dental changes, etc. But in acute intermittent porphyria, there's no cutaneous phenotype. So this acute intermittent porphyria is a little bit different than these erythropoietic porphyrias that result in these dramatic cutaneous phenotypes. Now, to reiterate this problem, again, synthesis of porphobilinogen through porphobilinogen deaminase and acute intermittent porphyrias and other hepatic forms of porphyria. Also important is the influence of lead. Lead poisoning blocks several of these enzymes. That's also in the differential diagnosis. But in the disease that we're considering today, acute intermittent porphyria, it's actually a porphobilinogenuria. The urine from these patients turns red and darker when you put it in sunlight. That used to be how we make the diagnosis, but measuring porphobilinogen is better. These patients get episodes primarily of abdominal pain, which can be elicited by certain drugs, but also by diet, alcohol, etc. And for some patients, this causes major medical problems and also is a rare cause for liver transplantation. So the study that we're going to look at involves the treatment of this disease. And the strategy that was applied in this study is called RNA interference. This is sort of a form of gene therapy where the translation, the change of the messenger RNA into the protein, in this case delta aminolevulinic acid synthase, is inhibited so that less substrate is produced for this particular enzyme that has the mutation for acute intermittent porphyria. This strategy has already received a Nobel Prize. MicroRNAs work along the same principle, well worked out in C. elegans, fruit flies, and man, as we see here. And the drug that we're looking at here is called givosiran, and givosiran is an siRNA against delta aminolevulinic acid synthase, ALAS1, if you will. And the drug has complicated structure. It has to have a certain backbone so that it's not degraded by enzymes. It also has to be able to enter the cells to work. So that's a little background on this problem. So what was done here is patients with symptomatic acute intermittent porphyria were randomized to givosiran or placebo in a complicated series of phase 1 studies. Now, what's done in a phase 1 study, first in man, is the normal volunteers or the patients are given a single dose of the compound. This is actually a study done to look at tolerability of this strategy. That was done in part A. In part B, the patients were given the drug once monthly injections. They received 2 doses of givosiran or placebo. And in part C, they again received once monthly doses of at least 4 injections of the compound to see whether or not the mRNA of delta aminolevulinic acid synthase was suppressed. So that was a strategy here. And these patients are generally treated with hemin. Hemin has been around for 100 years and costs practically nothing. It's basically a heme molecule with this extra chloride. You can get this in the slaughterhouse, if you will. And patients are usually treated with hemin in order to basically do the same thing so that the amount of the action of delta aminolevulinic acid synthase is decreased, and heman is not ideal. It has to be given parenterally, but it's also effective in this disease. So that's the discussion of heman. And a lot of these patients had already received, half of them had already received heman prophylaxis, in addition to other strategies. So here are the patients. 33 received givosiran, 10 received placebo, and the first thing that we look at is adverse events. And one of the adverse events is abdominal pain. Of course, abdominal pain is also a phenotypic manifestation of acute intermittent porphyria. Nausea, diarrhea, and nasopharyngitis occurred, but there were no differences in any of these outcomes between the placebo and the patients that received givosiran. Now, so if we look at the mRNA excretion of the messenger RNA excretion in the urine, we can see a dose-dependent decrease in messenger RNA excretion after a single dose and after multiple dose days after injection. And this is a dose-dependent phenomenon. And also the amount of porphobilinogen that's excreted in the urine decreased in a dose-dependent fashion so that it looks like the drug probably ought to work. And indeed, if we look at in the phase 3 study compared to placebo, this was the general pattern. So the porphobilinogen in the urine, the enzyme level in the urine, and the messenger RNA in the urine seemed to drop in a dose-dependent fashion in the patients that got the siRNA. And if we look at the mean annualized attack rate, and again, this was not really a therapeutic trial, this is a phase 1 study, but it looks like the patients that got givosiran had less attacks of acute intermittent porphyria compared to the patients that got placebo. Now we're looking at 10 in this group and 30 in this group. And again, this was not primarily a therapy trial, but it looks like the higher doses of givosiran probably decreased the synthesis of delta aminolevulinic acid synthase to a degree that episodes of acute intermittent porphyria would be diminished. Of course, this therapy is going to have to be tested against heman to really document the fact that it's better than what we are currently doing. So this exploratory analysis suggested that there were reductions in patients' attacks of an acute and intermittent porphyria in these patients. Some of you will know that King George III, he was the adversary of the Americans in the War of Independence, putatively had acute intermittent porphyria, which people believe, some historians believe, accounted for his occasionally bizarre behavior. Although Prince Charles thinks that he was a pretty good king. He's been cited as having said that. The first review in the New England Journal involves depression in the primary care setting. And this is an important review. We're given a patient, 45-year-old woman with hypothyroidism that's actually easily treated, comes in with depressed mood, negative feelings about herself, doesn't sleep properly, lost some weight, poor concentration, lack of energy. This state of affairs has been going on for several months, has some partner conflicts. These are common problems, and they concern patients that are doctors, most people, and the physicians that take care of these patients, the first doctors to see these patients are involved in primary care. So the decision that has to be made is by the physician is, how serious is this problem? Is suicidal thinking here a part of the problem? Can we distinguish, is this a simple depression, or is there actually a bipolar disorder here that's present here? That distinction is important. Is this a condition that should be treated with psychotherapy alone? And if so, which psychotherapy might be the most effective? And then, is drug therapy indicated here, and also which drugs should be administered? And so there are criteria for major depressive disorders and criteria how to distinguish bipolar disturbances from simple depression. And these items are discussed in this review, and you can look at them here. How many days per week is the patient affected? How does the condition interfere with the patient's daily lifestyle? Insomnia, psychomotor agitation, fatigue, loss of energy, loss of interest in outside activities, etc., so that we can classify these patients into mild, moderate, or severe, which is important for making clinical decisions. And of course, is the question, is there a suicidal tendency here? And the patients have to be asked these questions, and there are questionnaires that are effective in identifying patients that are at high risk, perhaps doing themselves harm. Have you wished you were dead in the past few weeks? Have you felt that you or your family would be better off if you were dead? Have you thought about killing yourself? And if so, how? And have you made any moves in this direction? And these situations have to be discussed. Now, numerous psychotherapies have been tried for depression, and they're all about equally effective. So I think it's probably a function of what the therapist is most comfortable with and in what he has the highest degree of experience, and then pharmacotherapy. And there have been numerous randomized trials of comparing one drug to another for patients with depression. Citalopram is commonly employed, and the response rates have been variable, but there's an entire list of drugs that can be applied here, and you can look at that on your own. It also depends upon the physician's experience and with what doctors generally do best with drugs that they know well and where they've had experience in applying these therapies. So this is an important, certainly an important topic, and the expert here feels that psychotherapy should be applied, but also recommends a drug therapy for this treatment. And obviously there are areas of uncertainty, and so you can examine this at your leisure. Another review in the New England Journal involves organoids, and this is a fairly complicated topic involving tissue cultures where several cell lines that are present in certain organs or tissues can be cultured along with their matrix. And these organoids are not yet actually suitable for producing an entire organ, but we can produce cell lines that work together as models and can also apply these for therapeutic trials of agents that might be effective here. And one example is modeling the intestine. These cells have to proliferate at a high degree. There's an orphan receptor called the leucine-rich repeat-containing G protein coupled receptor, LGR5, that's present in these basically stem cell lines this particular receptor involves so-called Wnt signaling that's important in proliferation. And these entire issues are discussed. Then these tissue culture models of various tissues that have been developed, including central nervous system, kidney, pancreas, liver, or gastrointestinal tract, or even models of malignancy where chemotherapeutic agents can be tested that might have some utility in treating cancer in patients. And that's the point in this particular, in this review in the New England Journal. Modeling disease, screening anti-cancer drugs, identifying drug toxicity, looking at the interrelationship between cell lines and extracellular matrix proteins, and the development of tissue architecture, etc. So this is a hot item. This is the patient from last week that had the cutaneous Malakoff Lakeya. This looks like a PAS stain, and as our pathologist consultant indicated, these Michaelis-Gutmann bodies invariably contain calcium, and there are stains for calcium that can be applied here. This patient's biopsy, tissue biopsy, grew out Escherichia coli and Pseudomonas aeruginosa. Long-term antibiotic therapy should be effective in these patients. This very unhappy looking individual has mucocutaneous ulcers that involve his mouth and his penis, and this looks very suggestive of Behçet's disease, which was first described by a Turkish clinician named Behçet, and this probably is an immune phenomenon that involves organs described here and is treated with immunosuppression with steroids and similar agents to try to help these patients. Now, the patient in the New England Journal is a 75-year-old woman who's admitted with a 4-month history of weight loss. She was born in Morocco and is a retired cook and lives alone. Her laboratory reveals that she has a hematocrit of 28%, so she's anemic. Her creatinine is elevated. Her blood urea nitrogen level is elevated. She has signs of inflammation. Erythrocyte sedimentation rate is elevated, and she has heavy proteinuria. So this looks like spontaneous nephrotic syndrome. And at this age, there are a variety of things that come to mind, but antibody testing was not helpful. No antibodies against hepatitis B virus or hepatitis C virus. Complement levels are normal, and anti-neutrophil cytoplasmic antibodies are also negative. A kidney biopsy is done that reveals 3 glomeruli, and she looks like she has, within the basement membrane, has immune deposits that are listed here, but there are only 3 glomeruli in the slide. We don't see the picture by light microscopy, so we can't comment more about that. The patient is started on a regimen of sort of empirical regimen of steroids without a definitive diagnosis, doesn't get much better, and then shows up with this rash. And we've looked at several of these rashes in the last in the last weeks, and the sudden appearance of this kind of rash in a patient this age suggests underlying malignancy. And indeed, this rash was biopsied, and it was consistent with cutaneous T-cell lymphoma. That could also be associated with the development of nephrotic syndrome. So in her skin biopsy, looks like there are a lot of immune cells that are involved here. Testing for the retrovirus that is associated with T-cell lymphoma was negative. Then additional tests were done, and the clinicians found to their surprise that this patient was HIV positive and has 156,000 copies of HIV virus per milliliter. This is not something that you generally expect in 75-year-old ladies from Morocco. She denied any sexual contacts, had not had any blood transfusions. Her husband had died 10 years ago. And the point in this case review is that even in older patients, we have to think about the possibility of HIV virus, and the discussant here indicates that about 5% of patients that receive a new diagnosis of HIV are above age 60 nowadays. In the New England Journal, there was a brief report on heart transplantation, and the good news is that heart transplants the availability has improved somewhat in the United States, so that the waiting list for heart transplants decreased. Then it rose again a little bit, but now again it's falling. And the availability seems to be related to the number of people that are dying of opioid overdoses. And that was the point in this letter to the editor in the New England Journal of Medicine. Now, in the Lancet, the whole journal was devoted to the issue of gender gaps. And one of the papers involves another natural experiment at the national funding agency levels. And what was done in the UK is they looked at grants awarded by MRC to male and female investigators, and then also the reasons why the awards were granted or why they were not. And there are numerous female investigators applying for these awards, and the awards appear to be given more commonly to men than women. And in this analysis, the judgment of the science was no different between genders. That means that the reviewers of these grants felt that the scientific hypotheses, the methodology, the scientific designs presented by the women were at least as good as those presented by the men. And so the question is, why were less women being funded? And the answer seems to lie in the fact that the reviewers view the capability of these women as principal investigators as being less capable as the male applicants. And we're not exactly told why this is the case. Being a reviewer myself, one of the things that we do is we look at PubMed to see what the people have published. And it's possible that the male applicants had better CVs in terms of past performance than the women. But the answer from this analysis is not clear, but it seems to be the case that although the science that the women present is as good as presented by the men, they're judged to be less capable as principal investigators. And of course, that may also be a function of injustice rather than past performance. And the second paper in the Lancet involves why do women leave surgical training? And there are 12 female surgeons that discuss this issue, and there are concepts concerning habitus and feminist theories and feminist research methods, etc. But basically it boils down to long working hours, fatigue and sleep deprivation, a lack of learning opportunities, bullying, the usual suspects that I would think would probably be responsible for why both genders might leave these particular specialties. So that's discussed in this particular paper. Then there's a review in the Lancet that looks at the role that women play in the healthcare workforce, and I couldn't really believe this, but all of the white areas in this map are areas of no data. And according to the authors, there are no data about females present in the workforce in all of North America, and even in Australia. But it seems to be the case that women play a major role in some countries of at least 70 to 80% of the workforce of the entire healthcare system is based on the work of women compared to men. But apparently no data from these other countries. The share of employment in the healthcare and social sectors, the proportion of women researchers, that's given in North America, and the proportion of women researchers seems high in the United States and Canada, but apparently nobody's paying too much attention in terms of how much healthcare they're providing. I thought that was interesting. And here are various graphs that show what the changes have been over time. So here's a paper out of JMA that I thought was important. It involves maintaining graft patency in patients that have been subjected to coronary artery bypass grafting. And in this prospective randomized trial, P2Y12 inhibition and aspirin were compared. So these patients received either aspirin, ticagrelor, or a combination of both. And there were 500 CABG patients that were randomized to these three treatment arms after operation. And then the endpoint was how many grafts, how many saphenous vein bypass grafts are open at the end of a year. Well, thank goodness most of them were still open, but not all of them. And if we look at the distribution of the patients, the randomization seems to work, and most of the patients are male, and they have hypertension, and they have diabetes, and bad cholesterol levels, and syntax scores in terms of their severity of their coronary disease, and these things are given here. And their drug treatments, that was similar. But what we see here at the end of 1 year, we can look at 1 year saphenous vein graft patency. And in the combination therapy, ticagrelor plus aspirin, it looks like 88.7% are still with us. And with aspirin alone, it's only 76.5%. So the absolute difference between these two treatments is 12.2%. And if we look at, that's the intention to treat distribution. And if we look at the investigator conclusions, the difference is similar. The point here is how to calculate number needed to treat. And the number needed to treat is what's important here. And if we look at these differences, looking at ticagrelor alone compared to aspirin, ticagrelor still looks a little bit better, but these items are rarely significant. But the combination of these two compounds seems to offer an advantage. Now, if we look at the bleeding episodes, we can also calculate a number needed to harm. And this concerns non-cabbage related bleeding, and that lies by 21% absolute difference between these two treatments. So in their discussion, the authors say, this is really great. We only need to treat 8 patients to prevent one closed saphenous vein bypass after 1 year. But in this little criticism here, shown in JMA Guide to Statistics and Methods, we also need to be able to calculate the number needed to harm to make a clinical judgment. The point here is that clinicians should be able to make a judgment on what's claimed in the papers in terms of number needed to treat or number needed to harm. There was also a small blurb in JMA involving ophthalmia neonatorum. We looked at this several weeks ago. There are no good randomized trials on this. When I was in medical school, silver nitrate drops were given, which are quite irritating. The authors here feel that an erythromycin salve at the moment seems to be the best bet. Then I looked at my German passport that I've had for several years now, and the passport picture, I wasn't allowed to smile, and the photographer turned several photographs down because I smiled. What's the point here? And I was told that the passport office has to be able to make an identity here, and that's the purpose of these pictures. Well, I think that this strategy from the 19th century is not as good as fingerprints that are also from the 19th century, but perhaps we should apply something to identify people that's from the 21st century. And there was a discussion of this issue that was published in Science, in a portion that they have called Science and Law. And the authors here argue is a time for a universal genetic database so that we identify people on the basis of genetic markers rather than photos without smiling or fingerprints. And the example that's given here is the Golden State Killer, a murderer in California that killed numerous women, tortured them before he killed them, and sort of taunted the investigators looking for him. He left plenty of DNA specimens, but since he was in no database, he couldn't be found. So what the authorities did here is they registered him in one of these genetic personal identifier databases for people that are interested in their ancestry. And through this database, they were able to find some distant relatives of this individual. And on the basis of these distant relatives, they were finally able to apprehend him. So what they did is they constructed their own genetic forensic database to find him. Well, maybe pretty clever. I imagine that in a US court, this will probably be upheld. In a European court, they might throw all this out and turn the man loose. But that's discussed in this, the idea of a universal database. And I think it's time for universal databases so that we identify people with some accuracy instead of relying on photographs and fingerprints. And in a court case that ended up in the European Court of Human Rights, Marper versus the United Kingdom, the court decided that indefinite retention of biological samples and profiles including not only genetic data, but also fingerprints and other biological information, is a violation of the right to privacy. Well, how is this different than a fingerprint or a photograph of an individual? And most individuals place their photographs into some database such as Facebook, etc. That's the discussion here, and I thought it was interesting and probably important. Maybe that's one reason why the UK wants to leave the European Union, so that they can establish a universal database. Now, we'll end with this case in the New England Journal that involves a patient that was found unconscious in a park, sitting next to this jug of green liquid. That probably gives the situation away, or it would have 15 years ago, probably doesn't anymore, because cars don't need to have antifreeze anymore. They used to have antifreeze, and then we always had a jug of it in the garage, but that's not the case anymore. So this patient comes in with a blood pressure of 90/50. He's breathing 16 times a minute. He's somnolent, but he responds to pain. Otherwise, his physical examination is not helpful. Some laboratory studies are done. Somebody looked at his urine, which I thought was remarkably positive, because the urine was positive for calcium oxalate crystals. Now, if we look at his laboratory values, they're not very indicative. His bicarbonate is 21. We would expect a value of 40. If we calculate his anion gap, it's 14. Well, it's almost normal, but it's not normal, because the anion gap should be 12 and not 14. So it's slightly elevated, not too helpful. Has some blood gases made. His PCO2 is 38, ought to be 40. His pH is 7.32, ought to be at least higher than 7.35. So we're asked some questions here, and we're given a patient that's a 65-year-old heroin abuser who comes into a hospital. He's got a pH of 7.2. His PCO2 is 82. So does he have alkalemia or acidemia? Well, since his blood is acidic, I guess it's acidemia. Now, since his PCO2 is 80 and his bicarbonate is elevated, this has to be a respiratory acidosis instead of a metabolic acidosis. So we're given this as sort of a warm-up. So back to our patient. So here he is, and he has a pH of 7.32. That's lower than 7.35, so he has an acidemia. Now, is this a respiratory problem or a metabolic problem? And since his bicarbonate is less than 24 and his PCO2 is less than 40, it has to be a metabolic problem. Then we can calculate whether or not his compensation for this metabolic acidosis is appropriate. And we're given this complicated formula that I guess is now vogue, how to do this in the United States. The way I look at it is the decrease in the PCO2 ought to be approximately the same as the decrease in the bicarbonate level. And his bicarbonate decreased from 24 to 21, so I'd expect him to have a PCO2 of 37. It's 38, so that's pretty close. So what's the cause of this metabolic acidosis? And if we look at his serum osmolality, in Europe, where these things are done in SI units, we can just merely add the milliosmoles. In the United States, we have to change the glucose to millimoles per liter and the urea nitrogen to millimoles per liter. And when we do that, we find out that his measured osmolality is a little higher than his calculated osmolality. That might suggest that something is on board here that doesn't belong here. So drug levels are measured. Various things are negative. Ethylene glycol says in process. That's always disheartening to get that. But he has taken some amphetamines, but they shouldn't raise serum osmolality. Then when we're asked, what should we give this patient? And what we would like to do here is block alcohol dehydrogenase. And we used to do that with alcohol, but now we have fomepizole. Fomepizole in our emergency room costs 4,000 euros per dose. So our administrator says, hey, if vodka works as well, why don't you stick with that? So I don't think that we have fomepizole in our emergency room, but you should probably have it. So we give this patient fomepizole. And when we give patients fomepizole, we block alcohol dehydrogenase. That blocks the production of glyoxylic acid and glyoxylate, and oxalic acid and oxalate. And fomepizole should be given with thiamine and pyridoxine and folate, but we should probably give these vitamins to anybody that shows up in coma that looks like he might have been ingesting too much alcohol. So they send this poor young man to a psychiatrist, which I guess is a good idea. And so the teaching points here is identifying acid-base disturbances, being aware of the osmolar gap and the resources that we have available, such as fomepizole, to deal with this problem. Thank you very much for your attention, and if you're interested, you can hear the same stuff in German in 4 minutes.